Welcome to the Therapeutics Chronicles. I'm Mu'min Wali, and today we are talking about acetaminophen. It is everywhere. You see it in hospitals, community pharmacies, and patients picking it up off the shelf all the time. But here's the thing. Even though it is one of the most commonly used medications, it is also one of the most misused. Overdoses happen more often than they should, interactions get overlooked, and dosing mistakes, especially in pediatrics, are far too common. So let's break it all down today. We are going to go over how it works, common pitfalls, and the things you need to watch out for in daily practice. And as always, let's make sure we catch mistakes before they catch us. Before we get into it, just a quick reminder. If you are preparing for board exams, check out our Telegram and WhatsApp study groups in the description. You can also connect with me on LinkedIn if you would like to keep the discussion going. And if you have any questions or suggestions, you can always reach me at thetherapeuticschronicles@gmail.com. Alright, let's get into it. So, acetaminophen is mainly used for pain and fever. But what is interesting is that we don't fully understand its exact mechanism. The most accepted explanation is that it inhibits COX-2 in the brain, reducing prostaglandins that signal pain and fever. But unlike NSAIDs, it has minimal effect on COX-1 and peripheral COX-2, which is why it does not reduce inflammation. That's a key distinction. It's why we do not use it for things like rheumatoid arthritis or acute gout flares. But on the plus side, because it does not affect the stomach lining or platelet function, it is often the safer choice for patients with GI issues or those on anticoagulants. Now let's talk about metabolism, because this is where things get dangerous. Once ingested, acetaminophen is absorbed quickly, hitting peak levels in about 30 minutes to 2 hours. The liver does most of the heavy lifting here. About 90% is processed safely through glucuronidation and sulfation, and about 5 to 10% gets converted into NAPQI, which is the toxic metabolite. Normally, glutathione neutralizes NAPQI, making it harmless, but when someone takes too much acetaminophen, glutathione stores get depleted and NAPQI starts damaging liver cells. And here's the tricky part. Liver toxicity does not show symptoms right away. Patients do not walk in complaining of liver pain. It takes 24 to 72 hours before any real signs appear, like nausea, right upper quadrant pain, or jaundice. And by that time, the damage is already done. This is why early recognition is so important. If you catch an overdose within the first 8 to 10 hours, N-acetylcysteine, NAC, can prevent liver failure. But if you wait too long, the prognosis gets a lot worse. Now, let's talk about where things get wrong in practice, because these are the mistakes that happen over and over again. One of the biggest issues with acetaminophen is accidental overdose from combination products. It is in so many different medications and people do not always realize they are doubling or tripling up. You see it in opioid acetaminophen combination like Percocet and Tylenol 3. Cold and flu products like NyQuil and Dayquil. Patients take a Tylenol extra strength for pain, then later grab a nighttime cold medicine. And before they know it, they are well over 4,000 milligrams per day. They don't think of it as overdosing because they are taking different products, but the total adds up quickly. This happens a lot in chronic pain patients who use acetaminophen regularly. I have seen patients with elevated liver enzymes who swear they are only taking Tylenol a couple of times a day. But when you ask about any other OTC meds, that's when they realize they have been getting extra acetaminophen without meaning to. So the lesson here, always ask what else they are taking. Patients often do not think of OTC meds as part of their regimen. And that's how these overdoses slip through the cracks. Another issue that gets overlooked is acetaminophen and warfarin. It's often recommended for warfarin patients because it does not increase bleeding risk the way NSAIDs do. But high doses can increase INR. I have seen cases where a patient on warfarin starts taking acetaminophen 1000 mg 3 times a day for a week, and suddenly their INR jumps to 5 or 6, putting them at serious risk for bleeding. The mechanism is not entirely clear, but it seems to interfere with vitamin K-dependent clotting factor metabolism, leading to delayed INR elevation. So what is the takeaway? If a warfarin patient is using acetaminophen regularly, INR should be monitored closely. If it is just occasional use, the risk is low. But once they start taking daily doses of 2000 mg or more, it is time to watch INR levels and adjust the warfarin dose if necessary. And then of course, there is pediatric dosing errors, which happen way too often. Either underdosing, which makes it ineffective, or overdosing, which can be dangerous. And a lot of this comes down to incorrect measuring tools. Parents grab a kitchen spoon instead of a dosing syringe, and that leads to inconsistent dosing. A teaspoon at home might be anywhere from 2 ml to 7 ml, and that's a huge difference when you are dosing a small child. The best practice here? Always dispense a dosing syringe with liquid acetaminophen, and make sure caregivers understand weight-based dosing. 10 to 15 mg per kilogram every 4 to 6 hours, maximum of 5 doses in 24 hours. If a parent says, I just use a spoon, that's your cue to step in and educate. So let's go through some real-world cases. A 55-year-old with chronic back pain comes in with elevated liver enzymes. He insists he is taking only Tylenol, but after some questioning, it turns out he is also been using a nighttime cold medication that contains acetaminophen. He had no idea. That's a classic example of how these overdoses sneak up on patients. Or how about this one? A 68-year-old on warfarin starts using acetaminophen 1000 mg 3 times a day for headaches. A week later, routine INR monitoring shows it jumped from 2.4 to 5.1. That's a serious risk for bleeding, and if his INR had not been checked, it could have led to a major complication. And then there is the pediatric case. A 3-year-old with fever whose parent gives them a teaspoon of acetaminophen, but it turns out to be twice the recommended dose. The child needed hospital observation for hepatotoxicity, all because of improper measuring tools. So what are the key takeaways? Always check for hidden acetaminophen in combination products. Be mindful of INR changes in warfarin patients using acetaminophen daily. Reduce the max dose for chronic alcohol users to 2000 to 3000 mg per day. And make sure pediatric doses are measured correctly. No kitchen spoons, only dosing syringes. Before we wrap up, let's do quick Q&A to reinforce what we have covered today. What is the maximum daily dose of acetaminophen for an adult with normal liver function? 4000 mg, that's absolute max, and ideally we aim for lower doses when possible. What is the biggest risk of exceeding that limit? Liver toxicity due to NAPQI accumulation. If glutathione stores get depleted, you are looking at potential hepatotoxicity, which can be irreversible if not caught in time. Which common anticoagulant requires closer INR monitoring when acetaminophen is used regularly? Warfarin. Chronic acetaminophen use, especially doses over 2000 mg per day, can elevate INR levels, increasing bleeding risk. What is the most common mistake in pediatric acetaminophen administration? Incorrect dosing due to measuring errors. Parents often use the household spoons instead of syringes, leading to underdosing or overdosing. Always emphasize weight-based dosing and provide proper measuring tools. If an acetaminophen overdose is suspected, what is the antidote and what is the most effective? N-acetylcysteine, NAC, and it works best within the first 8 to 10 hours. The earlier, the better. If it started late, the damage may already be extensive. That's a wrap for today. If you found this episode helpful, make sure to subscribe and share it with colleagues. Let's keep the discussion going. Connect with me on LinkedIn, and if you have any question, feel free to reach out at the Therapeutics Chronicles at gmail.com. And as always, medications are only as safe as the people who use them correctly. Catch mistakes before they catch you. Until next time, this is Mu'min Wali reminding you to stay curious, keep learning, and always question everything. See you in the next episode.